Hello, everyone. For those who don't know me, my name is Frank Tift. I'm an ER doc and EMS doc in Chattanooga, Tennessee. I want to take a minute to talk about spinal precautions in EMS, but really in the ER as well. There's been a recent position paper published kind of changing the guidelines of spinal precautions and who needs it and really what spinal precautions even are. So I think it's an important topic for everyone to be aware of. So moving right along, first off, I do not have any disclosures. No one pays me anything except for my job. I do have a couple of pictures of some spinal immobilization devices in this talk, but I'm not endorsing any particular brand over any other. So, full spinal immobilization, i.e. long spine board, head blocks, C-collar, strap them down, has really been dogma of trauma care for several decades now. The idea is that when somebody has potential spinal injury, you want to splint the spine and prevent it from moving anymore to try and prevent any further injury. There's really not a whole lot of evidence to support this practice. The idea came from some pretty low-level anecdotal evidence several decades ago, and there is a growing body of evidence showing both potential harm as well as that full spine board doesn't really hold the spine as still as we thought it did. And so this recent position statement came out, and it really advocates against routine use and reduces the indications for when it's necessary and even what is actually necessary, what is considered restriction or immobilization. So we're going to start off mostly talking about that position statement because that's the biggest thing that I want people to get out of this talk. Then I'll move a little bit into the history and evidence behind kind of where spinal boards came from and evidence of do they work and are they causing harm and all those sorts of things, and then a brief summary at the end. So the position statement is this: spinal motion restriction in the trauma patient, a joint position statement, was published in Pre-Hospital Emergency Care, I believe back in August of 2018, so pretty recent. And one of the great things about this paper is that it's a joint statement from the National Association of EMS Physicians, the American College of Emergency Physicians, and the American College of Surgeons Committee on Trauma. So really all the heavy hitters that deal with trauma care and putting people on backboards and taking people off of backboards had a say in this paper, and it has their weight behind it. So it's a pretty hefty document with regard to when we need to put somebody on a backboard or if we need to put somebody on a backboard. One of the first things they mention is kind of funny. They actually want us to stop using the term spinal immobilization, and that's because there's some evidence that our current practices really don't immobilize the spine as much as we thought it did. So they advocate moving to the term spinal motion restriction. But then what does that mean? So what is spinal motion restriction? What qualifies as spinal motion restriction? And as I've already kind of alluded to, you don't really have to use a backboard anymore. All it is a C-collar and keeping the head, neck, and torso in alignment. So trying to keep the spine straight. And that can be achieved really with any flat surface, the patient lying flat on any flat surface, and not just a backboard. So any one of these would count as well. Any ER people in the audience that don't know what some of these are, the one on the left is a scoop stretcher. It's designed to kind of, you open it up to where those sides are facing downward and you can put it around a patient and then close it up under them and pick them up with it. And then the one in the middle is a vacuum mattress, and then on the right, of course, is a standard ambulance cot that virtually every ambulance uses. Any one of these count as a flat surface for the patient to lie on and would be adequate spinal motion restriction if you got them with a C-collar lying flat on one of these surfaces and strapped down appropriately. One thing worth mentioning that they did stress in the paper is that they do not feel that you can keep the spine properly aligned in a seated position. So the KED that we were all trained how to use to get somebody out of a car, you should definitely still use it to get them out of the car. But once they're out of the car, that does not count as spinal motion restriction. They need to have a C-collar on and be lying flat on a flat surface. But once again, that does not necessarily have to be a backboard anymore. So who needs spinal motion restriction? What are the indications? It's really blunt, and I emphasize blunt, trauma with suspicion of spinal injury and any one of these five things. Acutely altered level of consciousness, so GCS of less than 15, or intoxicated in some way. Midline back pain and or tenderness, focal neurologic signs and or symptoms, any anatomic deformity of the spine, and distracting circumstances or injury. And by this, they discuss it a little bit about what exactly this means. Really, it's something that impairs the patient's ability to contribute to a reliable exam. So if they do have a horribly painful injury, but you feel like they're reliably contributing to the exam, that might not necessarily be a distracting circumstance or injury. But if they are distracted, then you should put them on restriction. So I emphasized blunt up there at the beginning of this slide. What do we do with somebody that has penetrating trauma? The answer is really don't do anything here as far as restriction. You don't need to immobilize them in any way. And this is based off of a practice guideline released in the Journal of Trauma and Acute Care Surgery last year, 2018, from the Eastern Association of Trauma. And the data that was used within that guideline to recommend this is that there was a paper that showed a 2.4 relative risk of mortality after penetrating trauma if put in spinal mobilization. The idea there is, if you think about it, a bullet or a knife or any other form of penetrating injury, relatively specific places that it hit in a small path of where they go. So it's relatively low risk of actually hitting the spine, much less risk of actually hitting the spinal cord and causing an issue. And the time spent on putting somebody in mobilization is time that could be spent better further taking care of the patient or getting them to definitive care. So this is actually, again, not recommended that anybody with penetrating trauma needs to be put on any sort of spinal motion restriction. A couple of other important points. One is, since we're saying that you don't necessarily need to have somebody on a backboard anymore, one thing that a backboard is really good for still is transferring people. So getting them off the floor onto your cot, getting them from the cot to the ER stretcher, getting them out of a house, etc. But again, it is definitely not needed for spinal motion restriction. So just having somebody on an ambulance cot with a C-collar is perfectly appropriate as you roll them into the ER. In that situation, the transfer from cot to bed or from floor to cot or whatever, if you're not using a backboard, is a high risk area for potentially bending the spine in some way. And you just need to be really careful if you're not using a backboard about making sure you've got adequate personnel, one person holding C-spine and a couple people to perform the move to make sure that the spine is kept straight the whole time. Another really important point is transport time, as far as even if you used a long spine board to get them onto your cot and into the ambulance. If you've got a really long transport time, you might want to consider going ahead and taking it off, because they've got a higher risk of getting some sort of injury or negative side effect from it. So if you've got enough people, you can hold C-spine, do a log roll, go ahead and get them off of it, and just strap them down to your cot. And then kind of related to the thing I mentioned before, removal at the hospital. 2 points to make about removal at the hospital. One, if someone comes into the hospital on a spine board, please get them off as soon as possible because of the negative side effects that we'll go over in a minute. But both of that, and if they're not on one, once again, just make sure you've got the adequate personnel to do things appropriately. So if you're taking them off the spine board, make sure you've got somebody holding C-spine and the right number of people to do an appropriate log roll to get it out from under them. But again, it is perfectly appropriate now, based on this position statement, for EMS to bring in somebody in just a C-collar on the ambulance stretcher, and you just got to make sure you got enough people to draw sheet them over as safely as possible. May even want to get a slide board to help make this go as smoothly and easily as possible. Last thing the paper covers is what about the children? What do we do with kids? The biggest thing about children that they mention is that you should not put a child into any sort of spinal motion restriction just because they are a kid, and that you don't feel like you're able to communicate with them well about their symptoms. That is not a reason to go ahead and put somebody on. The reasons that you should put a kid in some sort of spinal motion restriction are any sort of actual complaint of neck pain, any torticollis, any actual neurodeficit, any altered mental status, and then some high-risk mechanisms of any sort of high-risk motor vehicle collision, high-impact diving injury, or substantial torso trauma. And they also spend a fair amount of time talking about how we've all heard many times before that kids have a bigger occiput, and so you can have them, by laying them flat without any sort of padding, their big occiput can cause C-spine flexion. So the younger they are, you really do need to put some shoulder padding under them in order to keep the neck straight. Really, that's it when it comes to the position statement and the main things that you need to know about how things are now and where we're trying to get things go, which is, again, just a C-collar and having them lie flat on some sort of flat surface is plenty. And it's really just blunt trauma with those 5 indications. And you don't need to worry about it with penetrating trauma at all. And really going back to those 5 indications, let me move back to them real quick. Something I forgot to say that I meant to say is a lot of people may recognize these as very similar to the nexus criteria. So the nexus criteria that we use in the ER a lot of the time to decide when we can take a C-collar off of somebody is essentially these same 5 criteria, where if they don't have any of them, we can take the C-collar off. So the reason to put a C-collar on somebody is if they do have any of those 5 criteria. So that's an easy way to remember it for people who are already aware of the nexus criteria. All right. Getting back to here, so next let's talk a little bit about the history and evidence of long spine boards and spinal immobilization, and kind of where they came from and why we're trying to move away from them. First off, where they came from is really some low-level anecdotal evidence. It started from this paper, Geisler et al. In 1966. And by the way, there's a references slide at the end where you can see all these papers that I'm talking about if you want to try and pull them. But Geisler, they published a case series of 29 patients who developed further paralysis through faulty handling. But even of those 29, they really only felt that in one of them would it have been prevented with proper precautions taken. So this is kind of where the idea of faulty handling came from. And then kind of the community debate surrounding this article, the idea of C-collar and backboard came up somewhere in that debate. And then that C-collar and backboard was included in the first EMS textbook in 1971, based entirely off of this one paper and the debate surrounding it. It really kind of got solidified into dogma several years later in 79, paper by Bowman, a case series of 100 patients out of 300 that had a C-spine injury who developed delayed paralysis. So 300 patients delayed paralysis after a C-spine injury, and then 100 of them, he felt like there were causes that were underappreciated by the emergency physicians. So the reason as to why this happened was pretty hotly debated. Interestingly, Bowman himself thought it was from local tissue swelling causing hypoxia and hypoxic injury to the tissues, leading to neurodeficit. But the community debate, the most popular theory was kind of moving back to this improper packaging and handling. And that's where universal adoption of spinal precautions came from. So it's really just kind of 2 papers and a lot of discussion that led to us putting everybody on backboards. So why are we kind of moving away from it now? Is there are definitely some negative side effects of backboards. First and foremost, that most people think of when you ask them about it, and particularly anybody who's ever been on one, is that they cause pain. They definitely cause pain. There's a paper by Chan et al. In Annals of Emergency Medicine in 1994, where they took 21 completely healthy, pain-free subjects and put them on a backboard for 30 minutes and then took them back off. And all 21 of them had developed pain, most commonly, as you might expect, in the occipital, sacral, and lumbar regions. Another interesting point from this paper is that 6 of those 21 patients, which is 29%, still had pain 48 hours later, some degree of pain 48 hours after being taken off the backboard. And so the problem there, as unsurprisingly, is potential for increased radiography. So if somebody has pain, you're going to not be sure whether it's from the injury or from the backboard, and end up getting more x-rays, even more CTs, causing more radiation and potentially more downstream effects from radiation, including possible cancer. Another side effect that not as many people think about is respiratory compromise. If you think about laying on a flat, hard board with a bunch of straps across your chest, it can make it pretty hard to breathe. And so there was a study by it was Bauer and Kowalski in the Annals of Emergency Medicine in 1988, where they took 15 healthy subjects, measured pulmonary function tests on them, then strapped them down to a backboard and did the pulmonary function tests again while they were on the backboard. And they showed a pretty significant decrease in functional vital capacity, FEV1, basically a restrictive pattern of lung disease for being on a backboard and having the straps across you. And then finally, another one that a lot of people probably heard about before is the possibility of pressure ulcers. So pressure ulcers, there's a fair number of papers actually showing association. The best kind of causation paper that I could find was one by Berg et al. In Pre-Hospital Emergency Care in 2010, where they used a concept from the wound care literature called increased sacral tissue oxygenation. The idea is that if any tissue, whether we're talking about anywhere on the body, has had compressive force to it for a while, that the blood has been forced out of the area, it's not getting oxygenated very well, and then you remove that compression and blood kind of floods back into the area and you get increased tissue oxygenation of that area now that the compression is relieved. And in the wound care literature, this measurement has been shown to be associated with development of pressure ulcers. And so Berg et al., again, Pre-Hospital Emergency Care 2010, showed increased sacral tissue oxygenation immediately following taking somebody off of a backboard. So clearly at risk of developing sacral pressure ulcers from being on a backboard. So that leads to Captain Kirk here starting to wonder about whether or not we should really be putting people on these backboards. But then, like everything in medicine, there's risk reward, right? So yeah, there's going to be some negative side effects, but are they doing what we want them to do? Are they preventing injury? And the answer there is not really as well as we thought. So there are some papers showing that it allows movement. So there's often slack in the straps. There's allows for axial rotation and lateral bending of the neck, even when it's been put on by practicing paramedics that have been doing this for years. Other papers showing there's still pretty significant amount of force measured across all directions. These papers were mostly mannequin studies where they would put motion devices on like the forehead and both shoulders and drive them around in an ambulance and measure how much movement was happening while they're strapped down. And there's really still a fairly significant amount of movement happening even when properly strapped down. But once again, that's not really a clinical measure. How much does it matter? Are there any improved outcomes? And in general, there haven't really been any papers that show improved outcomes, and there have been some that show worse outcomes. Most notably, skipping down there to the bottom, is that penetrating trauma one that I mentioned before, so the actual paper here, I believe I have it written down. This is from Hout, and I believe Hout is how he says it, from Journal of Trauma in 2010. Where we had double mortality in immobilized patients, 14% versus 7.2%, with an odds ratio of 2.06 for penetrating trauma after having been immobilized. But even blunt trauma as well. This was, there's a paper by Hauswald in the Academic Emergency Medicine in 1998 that showed less neurologic disability if they were not immobilized, with an odds ratio of 2.03 after blunt trauma. So really there's some growing evidence out there that it's not even really working. So you put that together with the fact that it's not working, plus you put it together with back here how it doesn't seem like there's all these negative side effects happening. Sorry, I kind of stumbled through my thoughts for a second there. So negative side effects plus it's not really working, and we've got, it's maybe not a great thing anymore. Maybe we shouldn't be doing this. And so that's kind of how we've come to where we are now in these papers and position statements that are changing the way we think about immobilization. So that's about it. Again, let's just summarize. The new term is spinal motion restriction. Spinal motion restriction means just a C-collar and lying on a flat surface, basically. You do not necessarily need to use a backboard, though backboards still are definitely useful for transferring patients, but if you're going to have a long transport, get them off. If they come into the ER on a backboard, get them off as soon as you can, and don't get mad at anybody who brings somebody into an ER not on a backboard anymore, because that's the direction things are going. The indications is essentially blunt trauma with the nexus criteria, where they meet any of the nexus measures instead of not having any of them. Do not use it for any sort of penetrating trauma. C-collar plus cot as quickly as possible, and by that I mean, I already mentioned it, is get them off the backboard as quickly as you can. C-collar plus cot is plenty and is not going to have as much negative side effects as a backboard. And definitely, again, be really careful with your patient transfers if they're off of a backboard. Have any adequate personnel, somebody holding C-spine, and people doing a proper draw sheet or proper log roll is really important. So with that, I'll leave you the references slide if you want to go find any of these papers that I've been talking about. And thank you very much for your time.